let's start the meeting. Obviously, this is the first meeting of Norfolk and Waveney CCG governing body. I'll just start by just noting the apologies from Claire Handling, who's unable to be here today. I think because we're doing it as a WebEx, I think it would be quite useful just to get everybody's microphones working, just to check that actually people are able to contribute. So I'm going to just go on the boxes that I'm seeing for people just to unmute, say that they're present, and then we can continue. So Melanie, can you do that?
Yes, hello everybody. I'm Melanie Craig here, Accountable Officer for the CCG.
Okay, I've got Karen next. Do you want to just can you talk, Karen?
Yep. Hi, Karen Barker, Associate Director of Corporate Affairs for the CCG.
Okay, and great, Kath, you're welcome.
Thank you. Kath Byford, Chief Nurse for the single CCG. Great.
Hilary?
Hi, Hilary Byrne, GP from the South, Governing Body Clinician.
I've got Hein next.
Hi, it's Hein van der Willenberg, lay member of Financial Performance.
Yeah. Jane, do you want to just check that your microphone's working?
Yeah, I'm here. Thanks.
Okay, great. John?
John Ingham, Chief Finance Officer of the CCG.
Okay. Kathy?
Yeah, Kathy Branson, Registered Nurse.
Okay. Mark?
Yes, Mark Jeffries, lay member for Patient Engagement.
Arden?
Hi, Arden Ross, GP, member from Yarmouth and Waveney.
Yeah, and then I've got, everybody's boxes have moved. I've got Rob. Are you there, Rob? Is Rob with us, Chris?
Rob is there, yeah. Rob, try again. I've unmuted you.
Okay, so maybe Rob's having some difficulty. I can't see his picture, so maybe he's got a poor signal. But he is there, is he, Chris?
Yes, he is in the participant list.
Okay, and welcome, Patricia. I know you're not part of the governing body, but you asked if you could be in attendance. So welcome, Patricia. Okay, so let's make a start. I think I wanted to.
Sorry, Anoop, it's Tracy here. You missed me. Can you hear me?
Ah, sorry, Tracy. I had the chat box in front of you. That's what it was.
Okay, can you see me and hear me? I just wondered.
I can see you now, and I can hear you.
Great.
Is there
okay.
Anybody that I've missed? No. Okay. Great. I mean, I think I just wanted to make a couple of remarks really at the beginning of the meeting. Obviously, we're not meeting as we had envisaged and planned to meet because we are in kind of extraordinary times of change and challenge. Even a month ago, even 2 weeks ago, how we were planning to run this first inaugural governing body meeting is very different to how we're doing it today. So even a couple of weeks ago, we were thinking of meeting in Lakeside and doing a live stream because we are supposed to have this meeting in public. But last week it became clear that wasn't the right thing to do. It went against guidance and sense. So we're having it by WebEx, but we are recording the meeting today, and we will make that available to the public, including I think probably on the website as well. So just be mindful of that during the meeting. So I think we're all probably in our homes, apart from I think there's a bit of Lakeside there, so I think we're not all at home. But I mean, for myself, I'm self-isolating as well and recovering from an ankle operation, and I know most people are videoing in from home. So thank you for doing that. Very briefly, I think we should just recognise that it's a new CCG that's been launched today. most of us have been involved in one of the, all of the 5 previous CCGs, and I think that they've achieved a lot. But I think that the main thing that we need to focus on is continuity and facing the challenge that we have. And I think I gave a talk to all the staff of the CCG this morning. One of the things I highlighted was that actually most of the staff that were working with us in the 5 CCGs are continuing to work with us. So the resource of our people is very much there. But the job that we've got to do is very different from what it was with the 5 CCGs, and particularly in recent weeks, the focus obviously has been quite rightly on dealing with the COVID-19 challenge, and I think that's what needs to continue. Once we're more onto business as usual, hopefully within a few months, we should then focus on what we saw as our main business, which is implementing the NHS plan. The long-term plan came out just over a year ago and set out the challenge really that we face in health and social care. And in particular, it was well received. People thought it said the right things about what the challenges were and some of the solutions which involve us working as organisations in health and social care much more collaboratively and transforming services rather than doing more of the same, which is what we've previously been used to doing. And the NHS plan was one of the main reasons why we merged from 5 CCGs into 1, because there's a need for a strategic commissioning organisation, CCG, to facilitate that collaborative working between organisations in health and social care. But in a sense, that's kind of the long-term plan. We're obviously facing a situation which is very different in terms of our priorities now, which is very much around helping the system to meet the challenge that coronavirus has given us. And it is the biggest challenge for the NHS and probably for the nation since the Second World War. Increasingly, I'm feeling that, particularly what I've seen in the last couple of weeks, that actually it's a huge challenge, but also it's an opportunity for us to actually do what it says in the NHS plan, which is to work much more collaboratively together across organisations. And I think we're having to do it because of coronavirus, and it's really making us out of necessity and urgency. And it's introduced a real sort of what I described this morning as a turbo boosting of the NHS plan because of necessity. And a couple of examples I'll mention to you, which is great to see actually, is, for example, in primary care, there's digital triage that's happening, and particularly just in the last couple of weeks, a majority of practices now are using digital triage for all their patient contact, and the majority of them are now using video consultation online, which practices had slowly started to bring that on, but actually, it's completely transformed the way that primary care is working. Likewise for the hospitals, they're in the process of introducing video consultations for outpatient clinics, which kind of, if you'd asked us to kind of make that happen just a few weeks ago, it would be like, oh, let's have a committee and it's going to take months, years probably before it happens. And it's happening because of necessity. And what I think I've found is that, I mean, this is a huge challenge for us, but it's really making people think about how we deliver services. And when we get over this COVID-19 challenge, we'll never go back to the way things were before, and we will have transformed services, and actually I think we'll have implemented large part of the NHS plan much more rapidly than we otherwise would. So I just wanted to say that as an intro, and you'll see from the agenda that we've got today that actually the focus of it is very much on dealing with the issues that face us now. So there's going to be some governance issues which are a necessity. There's going to be some overview of finance, which obviously is really important. And the main kind of issue is going to be an update on what we're doing with regard to the pressure of COVID-19. Unless there's any comments people want to make, we'll start the agenda as it is set out. So we've done apologies. Just had a chat about Peter Harrison missing. Called him. I think he's going to dial in. Okay, so hopefully Peter will join us. And Rob, can I just check, Rob, that you're here and that you can hear us? Because I can't see you just now. No, I can't. I still can't hear Rob, but Peter's joined us. I gather. Okay, great. I'll just check. Peter, can you hear me?
Yes, I can hear you.
Oh, great. Okay. We haven't really started the meeting. I've just done an introduction. So you haven't missed very much.
I could hear the introduction, but for some reason or other, the other bit wouldn't connect.
All right. Okay. Oh, good. I mean, the only bit of housekeeping really is that when you want to contribute, you need to unmute your microphone, but then do mute it back when you finish. Otherwise, it causes a lot of interference. That's really the only main thing. I still haven't heard from Rob. Can I just check, Rob? Are you with us? It doesn't. It sounds like there's a connection problem there. Okay. So any declarations of interest? I mean, there's a general reminder that in governance terms, there is a register of interests, which if you haven't filled in already, it's really important that you do that. And at the beginning of every meeting, I will check if there are any items where there may be or may be perceived to be a conflict of interest. So if you can let me know now, or if there is an item where there may be a conflict of interest, can you make me aware at the beginning of that item, please? Okay. So item 4 is pretty easy because there isn't a previous minutes. I mean, I don't know, Karen, you can probably tell me, in terms of governance, what happens with the minutes, agreeing the minutes of previous other CCG meetings. I don't know in terms of continuity whether we have any role in that or whether it's wound up in some other way.
Yes, it'll be, so basically because this is a new statutory organisation, you're not able to approve the minutes of the previous organisation. Of course, many of you weren't even at the meeting, so it'll be very difficult for you to do that. So what's happened is we have emailed the chairs of the previous organisations with the minutes, and we're waiting for all of them to come back and confirm they're happy. And then we'll probably do that via chairs action, but I'm not obviously liaising with the chairs individually as to what they want to do, but that's probably how we'll take it forward. And then they'll be available on our website for anybody that wants to see them.
That's great. Oh, thanks for that update, Karen. So no minutes to approve. Action log equally. When we, as we go through the agenda, there may be actions that arise out of that, but obviously at the moment, our action log is empty, so there's no items to report on. So we'll move to item 6, which is our response as an organisation to COVID-19. And I think, Kath, I know that there was a presentation that was sent earlier today. I'm hoping that we can have a look at that through the WebEx. Otherwise, people hopefully have got access to it. I'll allow you to start the discussion on that.
Thank you, Chair. Chris, are you displaying the slides or do you need me to? Thank you. And can you take it to a slideshow, please? Thank you. Suzette, can everybody see the slides on the screen? Lovely. Yep. Thank you. Okay, so next slide, please, Chris. Thank you. So as Anoop has set out in the beginning of the meeting, and essentially the entirety of the focus of the CCG, not just the CCG, but actually the whole of the health and social care sector within Norfolk and Waveney has changed as a result of the COVID-19. And so the slides that I'll take you through will set out some of the way in which we're doing that. So there has been some need to clarify our governance arrangements in place, and due to the need for the focus on what we are prioritising, there's been a need to refine some of the director lead responsibilities and portfolios that they're leading on, in order to make sure that there's a sufficient level of oversight, director level oversight, and work at pace in all of those areas. And I'll explain a little bit more about that shortly. This is a level 4 incident as declared by NHS England. A major incident has been declared locally, and so therefore it's been really important to recognise the reporting arrangements, clear lines of communication, and how we sit within the local resilience forum cells that have been set up across Norfolk and Suffolk. And again, there's a little bit more later on in the slide deck about that. Next slide, please. So in terms of our CCG objectives for this incident, we are accountable for coordinating the health response for the population of Norfolk and Waveney. And there are some points very specific about our responsibility. So we have to play our part alongside all of the other organisations within health and social care, and with particular focus on supporting the resilience of general practice throughout this incident. Not just delivering existing community capacity, but significantly enhancing the level of community capacity to support rapid discharge of patients from the acute hospitals. We do run some critical patient-facing services, particularly the prescription ordering direct service, and we do have a continuing healthcare function. We do need to ensure that financial and contractual issues are not a barrier to any responses within Norfolk and Waveney in relation to decisions that need to be made and enacted at pace. And we need to make sure that staff in general practice and the CCG have the digital capability to work effectively remotely. We obviously have to protect the safety and the well-being of our CCG staff, and we already have to be planning for effective recovery towards business as usual. Next slide, please. So in terms of the CCG response, in many of our communications to our staff and outside of the organisation, our purpose is to support frontline services. So there are some clear actions that we've been taking in order to do so. So we are fulfilling our duty to coordinate the health response for our population. And we are liaising with regional colleagues within the NHS, as well as the wider health and care system, and indeed the whole public sector within Norfolk and Waveney. And we, as a CCG, lead the Incident Coordination Centre for Norfolk and Waveney. We are redeploying staff, some of whom are to frontline clinical services, such as the prescription ordering direct service. We're sending some of our clinical and non-clinical staff to support discharges from within the acute sector, and some registered nurses or people with a clinical registration are working within provider organisations. But we've also redeployed staff within the CCG in order to put that enhanced level of focus and pace on the work that we're doing, for example, increasing the community capacity. Supporting primary care I've already talked about, but it's really important that we recognise the role of the CCG in doing so. So we have set up a single point of contact for questions, which is available by phone and email for practices in order to call. And Mark Burgess is the executive lead for that function, and it is a well-used service in order to make sure that practices feel adequately supported in the challenges they're facing. We're providing practices with the technology to enable remote working. This is including the rollout of WebEx licenses, the use of iPads, webcams and headsets. We are supporting the rapid deployment of technology to enable them to offer video consultations, and working with practices to share information, sharing data with the 111 service, and all of our practices are now doing this. and working with the PCN clinical directors on the use of risk stratification tools. And we also have a health and social care cell, which forms part of the tactical coordination group for the Norfolk Waveney Resilience Forums, and that's led by me. Next slide, please. So this is a visual display of where we sit within the resilience infrastructure within the NHS, but within the two counties that we straddle. So within the middle, obviously, national NHS and regional NHS sit there. And then we have our health and social care cell, as I've just referred to, but also our strategic command, which is chaired and led by Melanie Craig, our accountable officer. And alongside this infrastructure, we have the Norfolk Strategic Coordination Group and the Norfolk Tactical Coordination Group, but also reflecting our Waveney population, the Suffolk Strategic Coordination Group and the Suffolk Tactical Coordination Group. Next slide, please. So the slide in front of you gives a description or an explanation of the functions, the roles of each of those groups. I won't go through every single line necessarily, but the strategic coordination groups for Norfolk and Suffolk provide that strategic coordination across all of the public sectors and partner organisations. So this includes the police, the district councils, the county councils, business support, all the organisations that sit across the county of Norfolk and the county of Suffolk, which will have an impact on how we are able to support our residents. There are operational cells that feed into these groups in order to have focused work. So a good example of one of those operational cells is community resilience. And this is at the moment is really focused upon supporting those patients who've been identified as shielded patients and vulnerable patients in order to make sure that they have access to food and their medicines. And the Incident Coordination Centre, which is second from the bottom, this is the ICC that I referred to earlier on. And this is a 7-day-a-week, 8 a.m. till 8 p.m. Function that we fulfil as a CCG, where we have a role of reporting up within region and national level, but also coordinating communication and actions within the Norfolk and Waveney system. And we do have 8 work streams underway within the CCG to support the COVID response. Next slide, please. So the local resilience forum cells, they're set out on the screen. So some examples of these cells are cyber. We need the NHS, or the whole system is actually still a huge risk of cyber risk, because it's considered a time when the systems are vulnerable and there are opportunities to exploit, whether it be the NHS or councils or businesses or schools in that way. So it's really important that we pay due attention as a whole system in cybersecurity. And there is a cell relating to excess deaths. So nationally, internationally, is anticipated a higher number of deaths, and the excess death support cell focuses on the infrastructure to ensure that that's planned and prepared for. Next slide, please. So this is just a bit more of a detail in relation to the functions within each of the cells in the Norfolk and the Suffolk Tactical and Strategic Coordination Group. And there's the yellow box in the centre of this slide, gives a bit of detail as to some of the tasks and focus of the Incident Control Centre that we run as a CCG. Next slide, please. In terms of within the health and social care system of Norfolk and Waveney, we have some key groups that have formed as part of the COVID response. And I think, as Anoop made reference to earlier on, some of the way in which organisations are working, decisions are being made, and pace is being applied to the progress in order to manage and cope with the COVID challenge has been absolutely critical. So these three groups have been set up in order to coordinate and lead this response. So there's been a clinical capacity group that's been set up with some clinical members of the provider organisations, along with the Chief Clinical Information Officer, the Director of Public Health, and Hilary Byrne is the CCG lead, clinical lead, representing us within this group. There is also the Chief Executive Group, comprised of all of the CEOs, Chief Officers within the health sector, but also the Director of Adult Social Care and Director of Children's Services and the Director of Public Health, and they make decisions on behalf of the system as required. And then there's a Workforce and Wellbeing group led by Anna Morgan, who's our STP Director of Workforce, looking at workforce capacity and resilience during the incident, but also being very mindful of staff wellbeing. Next slide, please. So in terms of some of the work streams, I made reference a short while ago to the fact that we have got 8 work streams within the CCG, and the slide in front of you sets out those work streams. So we have primary care, the ICC cell, the prescribing, ordering, direct service, discharge and community capacity planning, risk stratification, finance, digital, and recovery. And you'll see that each of those 8 cells has an SRO, which is one of the executive directors. Next slide, please. So we have a strategic command meeting which sits daily, and each of those work streams reports into the strategic command in terms of progress, challenges, or risks. And as well as working with the system, we have deployed all of our 400 staff to work within those work streams whilst we still continue our statutory functions. And of course, we have a dedicated comms team supporting all of this. Next slide. So this is diagrammatic of our 8 operational work streams, how they sit reporting up into to Strategic Command, reflecting the Incident Coordination Centre and how that reports up to NHS England. And that's the final slide. So I'll stop there and either take questions or we can enter into discussion. Thank you.
Okay. Thanks very much, Kath, for those slides and talking them through. I don't know about others, but I can't see everybody, whether people have turned their videos off or whether it's just my internet, but I can only see at the moment Kath, Karen and Peter on video. I mean, if people want to come in for a discussion or questions for Kath now. Is that no questions, or did nobody hear what I was asking?
Hopefully it's because I explained it very clearly.
Yeah, which you did, to be fair. So that might be that that's the reason. So no questions. Okay. Does anybody want to make any comments in terms of what you've heard, or maybe what you thought you would hear that you haven't heard?
I'm not sure if you can hear me now.
Is that Rob?
It is. Yeah, it's Rob.
Hi, welcome, Rob. I can hear you.
Yeah, no, I have been on since the beginning, but I think it's a problem with the sound. I'm just wondering, from Kath's perspective, if there's anything that she's really worrying about at the moment.
Sorry, just a delay with taking the mute off. I think if I said that I didn't have concerns about what's ahead, then I maybe wouldn't have a grasp of the challenges that are ahead of us. But I think I would like to put that in the context of the significant amount of planning and teamwork that's taking place across the system, Norfolk and Waveney, the support we're receiving from NHS England at regional level, and the the real, I think, open and transparent conversations, discussions and dialogues that we're having across the system. So some of the obvious challenges that are ahead of us as a system will be about critical care capacity, but there are, as I say, there are plans in place working at a local level and at a regional level in relation to that. And then the other challenge that we're facing, which we are trying to anticipate, is that actually we still don't quite know enough yet about the impact of COVID in relation to not just the patients that go into hospital with the virus and the impact that has on them, but what that will then mean later down the line in terms of when they do need to be discharged home and what necessarily mid to long-term impact that will have and what services that we will need. But in reality, what we're doing is trying to be as proactive and as responsive as is possible based on what we're hearing on a day-to-day basis, and learning from areas that, like London, that are about a week or so ahead of us in terms of the disease progression.
Okay. Melanie's kindly chatted to me to say that she'd like to contribute. Can others do that as well if possible? If they want to contribute, they just leave a little note, then I'll know who to go to next. So, Melanie, you wanted to come in?
Thanks, Anoop. I just wanted to add to what Kath said in response to Rob's question, what are we worried about? I'm worried about three things are probably top of my list. One is personal protective equipment. Certainly, this remains one of the single biggest concerns for the whole health and social care system. We are reassured by just the amount of work that's going on at a national level, and it's very impressive. And there's lots we can learn after this from how the Army approaches logistics and how it approaches situations like this. The Army is working with the national team, and we're reassured that there will be a better logistical arrangement in place from Monday for smaller units of delivery, such as practices, care homes, hostels and other staff, to be able to access smaller quantities of PPE in line with what they need, as well as the trust. But at the moment, we are, of course, still waiting for the joint guidance between the Royal Colleges. That's vital, and trusts are facing issues. I know today about how, and have been up until today, about staff concerns. And so that's the single biggest issue, which to some extent is out of our control. We're waiting for a national solution. However, we are additionally trying to mobilise and take advantage of the incredible offers from Norfolk businesses, including the construction business, who are both offering their supplies to us and also offering to make supplies for us. So we're taking advantage of that. I have to say, we're not a logistics firm, so this is new to us to try and be able to meaningfully utilise all of that. But that's probably top of my list. Other top contender is testing. We rapidly need to enable our staff to be tested quickly and for the wider population to be tested, both in order to keep people in work who are providing frontline services, but also so that test to delay the spread of the virus. So I'm worried about that. And the third issue is that I think we're really concerned about is staff resilience and well-being. The intensity that staff are working at in all sectors and the pace that people are working at, you know, is going to be very hard to sustain. So I think I would just add those are the three things that I'm very mindful of and very focused on.
Great, thank you for that. Can either yourself or Kath, can you give me an indication in terms of testing? Initially, when we were in the containment phase, testing was available in the community, but obviously now it's just patients who have been admitted. Do we have have we got any local timescales for when, particularly in the community for healthcare workers, when they'll be able to have access to testing? Because I know that people are self-isolating and not being available because of not being able to be tested.
Thank you. So staff testing has commenced today. And at the moment, because of laboratory capacity and the actual disposables, the consumables that's needed, such as the reagents and the testing swabs, we're limited to 70 members of staff across the health sector a day, for which 25 of those 70 has been identified to prioritise primary care. So the acute hospitals, the ambulance trust and primary care at the moment are allocated a proportion of that 70 tests per day, but we hope that rapidly that capacity will be able to increase significantly, and it will either be to test staff or if they're self-isolating because of a family member. The idea would be to ideally test a family member who is demonstrating potential symptoms in order to then clear the whole household accordingly.
Can I just follow up on that? So the access to those tests, are we coordinating that through our primary care hub, or where's the decision made as to which tests should be done on whom?
So in terms from a primary care perspective, it's being coordinated by our primary care hub, and that's feeding then into the Norfolk and Waveney health infrastructure, that is all contributing to that testing process, so that the individual people who are to be tested, the names are given to the testing team to make sure only the right people do get the tests.
Thanks for that. Any other questions or comments from people? I'm not getting any. Peter, I can't see what your comment was. Did you want to come in, Peter? I know you made a comment about.
Yes, can I?
Got off my screen.
Yep. I'm not sure if this is appropriate. I'm a secondary care doctor. We know that certainly in secondary care there is a lot of doctor shortage, particularly in London, and there is quite some shortage at Norfolk and Norwich. The system for those of us who gave up our licence to practice in the last 3 years to then get back on into clinical practice is not working very well. I spoke to the GMC today because I'd heard nothing. And they said, oh, yes, no, you've got your licence to practice back, but our systems are not being able to notify the doctors who have got it back. And there's supposed to be a national coordination happening somewhere for those doctors who've got their licence to practice back to be contacted to see if there's any gap that they can fill. Is that something that you're aware of? Or?
I wasn't aware of it. But we can, I can take this to Anna Morgan, our Director of Workforce, to see whether or not this is a problem that's being replicated on a wider scale and what the imminent plans are to resolve the problem. Thank you for letting me know.
I think that is worth doing, Kath, because we were in a conversation yesterday with one of our ex-CCG chairs who actually wants to become available, and there was a similar issue that he highlighted in terms of the administrative side of being able to practice, and who would be providing indemnity, for example. That was a question that was asked. So I think Anna is probably the right person.
Yeah, I'll take that to Anna today.
Okay.
Thank you.
Sorry, the interesting thing just to finish that. The interesting thing I heard from the GMC is that anybody who thinks they should be getting a licence to practice back, if you go on to the register, you can find whether or not you've got it back or not, even though you won't have been notified.
All right, well, that's interesting. Maybe we'll communicate that then, because obviously if people are online, then they know they are registered. That's really helpful to communicate that. I've got Tracy who wants to come in.
Just unmute myself. My question is in respect of primary care. So aware of some of the system plans and with the various cells that we have and some of the capacity that we'll need in the community to support GPs, particularly primary care, and just really how well we're engaging with the PCNs and kind of their resilience during this, because clearly more patients being cared for in the community. The practices are going to be working in very different ways with their yellow, green and red sites going forwards, just so some of that kind of, some reassurance about the support for that and some of the plans.
Can I come in and answer this one, please, Anu? I think that we have deployed probably over a quarter of the entire CCG workforce to support general practice. Not primary care, but general practice. So there is a significant number of staff who are either working directly with practices or are fielding queries and responses to practices. We have established a dedicated primary care instant room with a dedicated email address and phone line, as you'll know, which receives well over 100 concerns which are actioned on a daily basis by a very large team. The associate directors of primary care and their teams are actually one of the parts of the CCGs that I am most concerned about because of the enormous demand on them in supporting what they are trying to do to support PCNs and general practice. The response we've had from, especially where there are 4 PCNs, I think by CCG, it's a by old CCG area, it's very intense and frequent support and flexibility. And I don't know that staff can do any more, actually, than they are already doing. And I really want to pay tribute to those staff who are supporting general practice and PCN. There's flexibility by PCN, and actually I think the PCNs themselves have just accelerated in terms of the way they are working together in their maturity over the last 4 weeks in a way that some of them may not have seen quite the need for them to work in this way before. We have a daily sit rep reported from each PCN into the CCG, and that forms part of the primary care sit rep as part of our strategic command in our EMT for the CCG. We review all of the sit reps for each PCN on a daily basis and spend time at an executive level dealing with some of the strategic queries and are constantly thinking about how we can further move staff around. I know that digital implementation has been one of the major issues for primary care, and on top of that quarter of the CCG workforce that I mentioned, we have furthermore significantly increased the digital implementation team for the CCG, so that we've been able to service and support with additional equipment and implementing digital transformations to more practice and PCNs in a very rapid timescale over the last 2 weeks. We continue to receive feedback about how we can respond and change during this crisis. And additionally, there is a daily communication that goes out to every single general practice at the end of each day, which summarises issues. And I myself write directly to practices with key strategic issues that I think are important to come from me to general practice directly. So that summarises our approach to PCNs and general practice.
Thanks very much for that, Melanie. Tracy, did you want to come back, or does anybody else want to make a comment either on that or the wider presentation on
just to say, no, I was aware of lots of those things, so thank you. It's good to hear it and for everybody to hear that too. That's really positive. And I think we had a conversation as governing body clinicians yesterday, and certainly Paul was highlighting this to us, that when there is good practice amongst the various localities and the PCNs, and certainly thinking about some of the ways the practices are working with colour codings, we want to encourage them to share that too, so that it is coordinated. So if someone's doing something really well, and I'm sure we're doing that, but I think that's something that we discussed yesterday as governing body clinicians.
So if I can just respond to that, because I absolutely agree with that. And that's why I think we took a very early decision as a CCG when we first stepped into this incident to stop managing through localities, but actually to manage strategically through one point of command, which is, so primary care is now being coordinated by Mark Burgess on behalf of the whole area. So we're not managing through 3 different points anymore. And that was so that we can get single approach, the best approach across the whole of Norfolk and Waveney, rather than encouraging different approaches when we frankly haven't got time and can't afford to take the risk.
Okay, thank you. Any other comments people want to make, or further questions? Yeah, is that Mark? Is that you wanted to say something?
Yes, I just wondered if we could hear a bit about the capacity within the secondary and the acute sector, please.
I can come back on that, Mark. So and Hilary Byrne might want to also comment on this. Very important that as a group of chief executives, we decided we needed to have a Norfolk and Waveney plan for capacity planning rather than in the very early days. I think people started to look at this as individual organisations, which obviously won't work. So there is a clinical group modelling, which Kath referred to earlier, with the Director of Public Health, Hilary as the GP lead, Erica Denton on behalf of all three trusts, and Venu, the medical director from the Community Trust, and Anthony Lundgren are doing the modelling for that. So they're looking at surge, and the trust looking obviously at that surging their additional capacity too. That doesn't include the field hospitals, which are being coordinated at a regional level for additional critical care capacity, but wherever it is in the east of England, it would accommodate patients from Norfolk and Waveney system. So there are a number of levels. There's the field hospital level, there's what more the three acute trusts can do, and of course as part of that I should mention that we have, under the new national contract that's been agreed, we are now fully utilising the Spire in Norwich and the BMI Sandringham for most and will soon to be all of our elective activity that's carrying on, and that has started, and all three hospitals are using that. So they're looking at that. Additionally, I think just in terms of releasing capacity more efficiently, Anoop mentioned in his introduction how Norfolk and Norwich has moved to 60% outpatients done digitally, and that obviously releases a lot more capacity. And Queen Elizabeth and James Paget about half of that, but improving. And additionally, our approach to how we're discharging patients from hospital and looking at patients that are medically fit and ready to go has transformed dramatically in the last couple of weeks. Kath might want to say a little bit more about that. The numbers of patients and bed occupancy rates in hospitals now, as we prepare to maximise secondary care capacity, are in around the as low as sort of the 50% mark. So that's also helping to contribute. I mean, helpfully, we're of course not seeing many people go into A&E these days, which is again something we would like to sustain at the end of and continue with when we come out of this period. And the numbers of attendance in A&E have dropped by over 50% in each of the three hospitals.
Thanks, Melanie. Kath, did you want to come in, or Hilary, in relation to the clinical capacity group?
Yeah, I can talk about that. Yeah, the group is working well. As Melanie said, it's working across all the acute and primary and secondary care. The idea really is that we have one agreed set of data, so that we are looking at a variety of data streams coming into that, but essentially one version of the truth in terms of where the data is at. It's looking at secondary care capacity across the three acutes, but also looking to feed in some primary care information as well now. So some of the things that Tracy referred to, trying to get that information into the model so that we can refine it. Obviously, it's a developing situation. The more data that we've got locally, the more that we can, make that more real for Norfolk and Waveney. But that is going well, and everybody's working very well together as a team. The other thing that I just wanted to just go back to a point Melanie made about primary care. I think there's a lot of things going on about primary care. The CCG staff are working really, really hard, and some of the things that they're struggling to get done are not really within their control. They're trying to solve some of the things that are national issues. But also things are developing, so there is a group that's now been set up which is being spread across the whole previous 5 CCG areas to share that information, expertise, experience across PCNs that you talked about earlier. So that is now in place, and I've been in contact with them about extending that to East and West, which everybody's very happy to do. So by the end of this week, that should be up and running as well.
Great. Thanks for that. Can I just make a plea to people, because I can only see about half of you. So if you're waving, I might not be able to see you. So do use the chat box if you want to come in, or just, or if you're obviously being ignored, just put your microphone on and interrupt. I won't take it personally. So any other comments or questions? Okay, well, look, I'll take that as a no then. Thanks very much for that update, Kath and Melanie. Obviously, this is something that's going to be our main kind of what we're focusing on in the coming weeks. But let's move on then, if people are happy, to the next item, which is some of the governance issues. And item 7 is to review and approve the Constitution. So, Karen, do you want to lead into that, please?
Yes, thank you, Chair. I'm conscious of time with this meeting as well, so if you're happy, Chair, I'll take the Constitution and the Governance Handbook at the same time, because they are linked. So basically, both documents are here for the governing body's approval today. Just to, as set out in the paper, the Constitution has been through some rigour already, albeit that we obviously couldn't do that with our current membership because we were recruiting our members at the same time as reviewing our Constitution. So just to bring everybody up to speed, the Constitution has been agreed by NHS England both at a regional and national level as part of the merger. We have also sent this and done a lot of work with practices, including quite a long engagement period with them to ask them their thoughts on the Constitution. And we have had no practices that have come back unhappy with the Constitution, actually quite a high degree of support for it as well. I wasn't going to take you through the Constitution itself in great detail because obviously it's 100 pages, it's quite a technical document. We have prepared a summary which hopefully aided everybody in reviewing the Constitution. I'm more than happy to take questions. So just to summarise, really, it is our rule book. It is how we will run. It sets out things around how the governing body works, what rights are reserved to our membership. It also highlights the committees of the governing body that support the governing body in its assurance, and we have 6 of those. And alongside the governance handbook, it provides the sort of total rule book for the overall CCG. Just turning to the governance handbook before I open up to questions on both documents. The difference between the Constitution and the Governance Handbook, the Constitution has to be approved by NHS England, whereas the Governance Handbook simply has to be approved by the governing body. In addition, the Governance Handbook does not require sign-off by the practices or any sort of review by the practices. So it's more going into more detail, really, around some of the aspects of the Constitution. Previously, you would have seen all this information in one large document, but recently, in the last year, NHS England decided to split it into 2, really, so that they focus purely on the core parts of the Constitution. So once the Governance Handbook is agreed by the governing body, that will also be put on the website. So it is a public document, but like I said, it doesn't require the extra sign-offs that the Constitution has had. So there are a few changes that have been highlighted to me. It's more what I'd call more administrative things that have been pointed out since the document's been circulated. I'm happy just to take you through some of those, but I thought before I do that, it might be useful just to open up to any other questions or comments that people may have.
Okay, thank you. So any questions or comments on both the Constitution and the Governance Handbook? Yeah, it's Mark, and then Hein as well, I think. So take Mark first.
Thanks, Anu. Just a couple. I'm conscious they sound slightly banal, some of these questions in the context of COVID-19. But Karen, on page 7, we've got a reference to in 1.6.1e, publishing an annual commissioning strategy. I was just wondering what the timetable is for that. And then the second question was on page 9, there's reference to the CCG may indemnify any member practice representative or other officers or individuals exercising powers or duties I suppose it's the lawyer coming out in me, but I'd just like to know what we need to do to trigger that, if anything.
Okay, so the first point on 1.6.1e, the commissioning strategy has been prepared, and usually in the usual run of things, we probably would have brought that today to go through fully with the governing body. But in light of COVID, we're obviously having quite a slimmed down meeting today, so we've done the bare minimum. So the commissioning strategy is there. We have done a period of engagement and some work on that, and John Webster led on that. That has gone to NHS England and been approved by NHS England. We have put it on our website in draft form, but we wanted to try and talk the governing body through that more, and also do some more engagement on that before bringing that for final sign-off. And obviously, in light of COVID, a lot of staff who would have been doing that work have been taken elsewhere. So I don't have an exact timescale for that, but there is something on the website at the moment. And we will probably catch up as a team very shortly about how we're going to, revise timescales in light of COVID on that. So does that answer your point on that? Yeah. Okay. And then on the next point, the indemnity. So this is quite interesting. This is model wording from NHS England, and actually it's not wording we have put in a constitution before, so it is quite new. But basically, it's been, from my understanding nationally, it's been put in because nationally some practices were quite concerned when they had the Lansley reforms in 2013 about exactly what a practice liability was by becoming a member of the CCG. I think having worked with CCGs for the last 8 years, I think in practice the answer is nothing really, other than complying with the membership rights within the Constitution, which is receiving the annual report, potentially holding governing bodies to account and things like that. So there isn't any liability in the sense of financial liability for practices as being part of the CCG. It's a requirement on them under their contract. So I think this is more in there for security, to make the practices aware, but it's not something that I think that we would end up having to pay out on. I can't foresee, and I haven't seen in the last 8 years, a situation where a practice has become in any way financially indebted or in some way to the CCG. So I think this is more around security. I'm happy to look into it a bit more with NHS England. Like I said, it was in the model wording and understand where it came from, but that's my understanding of where it came from. Does that answer your question, Mark, or would you like me to look into that further? Or?
No, that's fine. Thanks, Karen. No, we can probably have a chat separately as well.
Yes. Okay.
Thank you.
Okay. Hein, is that? I saw your hand moving. Is that intentional? Or?
Thank you, Chair. I was actually signaling thumbs up, like it's okay. So I need to be careful how I signal.
Okay.
I did send a few comments to Karen and Amanda this morning, but nothing mission critical, but just for completeness. Thank you.
Yes, if I may pick up on those comments, actually, there were a few sort of typo things that we have now fixed. It might be easier rather than going through them all now, because none of them were actually really critical. We could circulate a track changes version of the Constitution after this meeting if you'd like, but they were things just to give you a flavour, like there was some numbering that was incorrect. There's some rogue red writing in Appendix 6, which we have now tidied up. And the Appendix 7 was missing, but again, we've now put that in. I think it just got cut off the end in the PDFing potentially. So there's a few little bits and pieces like that. Anyone that made those comments, I'm happy to answer anything if they feel there's anything further on those.
Okay, I've got, I think Rob wants to ask a question and then Tracy.
Okay.
Okay, hopefully you can hear me, Karen.
I can, echoey, but I can hear you.
I mean, clearly there's a lot of very hard work gone into the production of all of the documents here, and you've been through a very comprehensive process of review and consultation. We got all the necessary approvals in place. My only question was, when would both documents be due to be reviewed?
Well, yeah, so the Constitution, there is no set mandated time when you have to review it, but we usually in governance at least review it once a year, but actually in practice it ends up getting reviewed more frequently than that because there are inevitably guidance changes and different things that we have to implement. With the governance handbook, you'll see in the paper that because of COVID, we didn't quite go through it in the detail that we would have hoped with all the new, in particular the new lay members and the officers all together in the rooms around the committee. So what I have suggested in particular with the governance handbook is that we do undertake a thorough review of that document before the 31st of July. Again, I'm guessing slightly on timelines there because I'm not sure how the COVID thing will develop. So as to what capacity officers in particular will have to look at that. But my main thoughts around that was just to work through really how the committees are working, how lay members in particular are finding them as well as other governing body members, and just check that we're all happy with those terms of reference. So I think in light of the unusual circumstances we're finding ourselves in particular, really be happy to go through the governance handbook again and do a review period before the 1st of July. And the Constitution, I'm open to ideas on that. Like I said, a minimum of a year, definitely we'd want to do it in a year's time. But if members felt that they would like to review it before that, again, we're happy to do that.
Thanks. I mean, can we put that on hold for a moment and just get Tracy's comments?
Yeah.
Yeah, mine was a comment really, and knowing all the hard work that Karen and the governance team put together in compiling the handbook and the Constitution, and the engagement that went with all of the practices and representatives from our Council of Memberships, the membership, I think just to comment and thank Karen and appreciate all of that hard work because it's a really good couple of documents, and certainly I know NHS England really were supportive of the approach to that as well. Just the question I had, I know that at the times of COVID we look at this in the future, but did we kind of really nail down how we will engage with those membership practices going forward once we're through the COVID? And because we had some thoughts about that, and I don't know if we kind of, I mean, I guess that's work in progress as well when the time is right and appropriate to do so.
Yeah, so I think the Constitution is very clear about how we're going to, I think you're alluding really to, in particular to the Council of Members and how that will work. So I have actually I've got prepared and approved actually an email to go out to practices, inviting them to organise their practice representatives and their nominated practice reps. As you'll remember, they're the ones that actually the 20 that sit on the council members. So that email was sort of ready to go, and it was very much up to the practices themselves in their groupings to work out how they wanted to put forward their representatives and how they wanted those representatives to feed back. I was about to press send on that when all of the COVID incident happened, so I didn't think it was appropriate for me to bother primary care with that sort of thing now. But as soon as we get through this into a way where primary care are able to consider this, then that's ready to go. So I think that's very, very clear and will be quite simple actually to set up. Then the wider point about how they work underneath that and how whether they meet in their former CCG groupings or how they want to work. Again, I think the locality directors were in the process of working that through, and it will be very individual for each area. And that wasn't something we really needed to worry about from a governance point of view. We didn't really need to document that as such, because I think it was more about how the areas work. And again, I think it's the same thing. The locality directors had got to certain points in that work, and then it's obviously now been paused in light of COVID.
Thank you, that's really helpful to know. Thank you.
Okay, thank you. Any other comments or questions on the governance?
Just a small comment from me. Where do we get hold of these documents? I've not had them or seen them.
Oh, okay. You should have been on the mailing list, Peter, for your...
I wasn't at that moment in time.
Oh, okay. I think what happened with you in particular was we've just set up an NHS net address for you, so they may well be sitting there, but if they're approved today, then they'll be on our website for the public. I'm happy to just forward them to you directly now after this meeting to make sure that you've got them personally, if you like.
Thank you.
So Peter, did you get the agenda pack?
I've only got a part 2,
Okay.
at 3 o'clock, which is my confusion.
Okay.
Okay, we'll look into that, Luke.
Okay.
See what happened there.
Okay,
Yeah.
no problem.
Yeah.
It'll sort out.
Can I just check, Jane? I don't think I've got part 2 papers, so if they haven't been sent, they might have got deleted maybe. So if there is an agenda for part 2, if you could just send that to me.
Yeah, they're fine. They were sent quite late this afternoon, so that's probably why you haven't seen them.
Ah, right, okay, I haven't seen that. There might be just in my inbox, but I haven't had time to look at it. Okay, thank you. So unless there are any other questions, but I know there were some comments on some of the detail, but I don't think any of it precluded us from approving the minutes, not the minutes, approving those documents, the Constitution and the Governance Handbook. So are you in agreement that we should approve in terms of the question about review? And I think the suggestion was it should be a year, but obviously it can be brought forward as necessary. Are people happy to approve? And a nod will do, I think. Okay, yeah, great. I saw everybody nodding. So that's great. And can I thank you, Karen, for, I know this has been an enormous piece of work. Actually, I think the engagement that we've had with practices has been fantastic, particularly when you consider other parts of the country where actually things have gone badly wrong. So well done on that, and thank you for your hard work.
Thank you.
Okay, so let's move on to item 9, which is the financial plan. And John.
Thank you, Chair. I hope everyone can hear me okay. Obviously, in the normal run of things, we would have had a chance to have some development time with the governing body to take through some of the background. But in the absence of that, we've got a financial plan here to approve today. That's a core part of the governance of the CCG at the start of the year. So it's even within the COVID situation, it's important that we bring it through for approval today. What we'll then do following, hopefully, the discussion and approval, we'll then be able to set some budgets and be able to get on with an element of budget monitoring in year. I think it's very important to say that the plan was set based on a lot of work that was done before the COVID-19 situation. There've been a lot of good system-wide discussion over a number of months, actually. And whilst we were facing some significant financial challenges as a system, we were very much working it through together in a much better way than I think we had done in previous years. COVID clearly has had a huge impact on what we've been doing on financial and operational planning, and the paper alludes to that a little bit in the summary. But for instance, hopefully everybody is aware that nationally there's been a halt called to operational planning and contracting processes until further notice. Nationally, they've actually calculated the contract values that we need to pay as a commissioner to our main providers for the period April through to July, just so that everybody's got certainty. They're nationally commissioning the independent sector capacity from 23rd of March, so that changes. And obviously, in the normal run of things, our acute contracts in particular would all be based on activity. You look first at activity, the trends, then you look to apply costing and pricing to that, understand what transformation might happen. The shape of activities we've known it in the past is clearly changing enormously in this period, and who knows where that will go again as we come out of the response period to COVID. So therefore, a lot of the work that we had been doing clearly has to be parked. A lot of the transformation work that we've been doing, interestingly, some of it will be parked if it was longer term, but a lot of it, as Anoop alluded to earlier, a lot of it is actually being completely accelerated. So outpatient transformation, the aspirations in the long-term plan that 30% of outpatients are removed from the acute setting by the end of 2024, pretty much. That's been done overnight almost with all the huge changes that have happened. So a lot of what we might refer to as QIP or transformation in the past is part of a longer-term program of work. A lot of that is actually happening now at pace. Melanie mentioned earlier that any attendances have literally halved over the last week or two in our 3 main acutes. So COVID has had a huge impact on the planning. The other thing to mention in relation to COVID is that nationally, clearly there's been significant announcements around funding available to support the costs for all NHS organisations in supporting the response to COVID, that absolutely money must not be a barrier. So we're part of a process on a regular basis of capturing the costs that we're incurring, that our partner organisations are incurring, to make sure that we can then claim that funding back and it doesn't impact on our delivery of our financial plan through this year, the remainder of this year and into next year. So with that big caveat, and basically the document that you've got in front of you is a point in time that was a few weeks ago, was work in progress at that point in time. We'll need to revisit it as we go through this year, as we return to something approaching normality in several months to come. But if I can just take you through briefly the document that was shared earlier, and apologies, Peter, you won't have this then because it was part of the agenda pack. So just a few things that I'll mention. A little bit of background. Hopefully everybody is aware that the NHS collectively had to submit our long-term plans as local systems. We had to do that last November, and that included financial trajectories. So the planning process we've been through was intended to really lift the first year of that longer-term plan and adopt that as our 2021 financial and operational plan. Clearly, some things have changed since we did that work in November, and the regional approach was very much about understanding those movements from the November submission. What that required for us as a CCG, we had a financial trajectory, what used to be known as a control total, which said we needed to deliver a 0.5% surplus in the financial year that started today. And that surplus is about £8 million, 0.5%, because we spend £1.6 billion per year. So that's our target, and that surplus is a contribution that we have been asked to make in line with all other organisations within the East of England. It's a contribution to a regional risk reserve held by NHS England and Improvement. In terms of overview of the plan, within the executive summary, there's business rules that they're called that all CCGs are expected to meet. That's around things like agreeing the financial trajectory, delivering a 0.5% contingency, meeting investment standards around mental health, which has been there for a few years, but also new for this year, an investment standard around community and primary care services, which gives a minimum uplift that we should apply to those sectors. The plan that we've got in front of us today meets the majority of those business rules. In particular, I point out it does meet the mental health investment standards as a critical area where we need to continue to increase our investment. As it stands, though, it doesn't meet the rule of us setting aside a 0.5% contingency, but I think we would argue that we've contributed to that regional reserve by a 0.5%, which as a contingency held at a regional level. But more importantly, it doesn't hit our financial trajectory that we're asked to meet by NHS England. We're about £6 million off that. Now, this is an issue. This was part of an overall £60-odd million challenge that we were facing as a system, as I alluded to earlier, we were discussing before the COVID response kicked in. And we were committed to looking to bring down that £6 million gap. Because the work stalled, we haven't been able to address that. The reason that arose really was there were a number of ups and downs, but since the November planning period happened, the national prices that finally came out that applied to the activity that we commission in Norfolk and Waveney, the price of that was around £6 million more than we'd anticipated before. So there was a fundamental change in the national assumptions that we were applying that's meant that as things stand in the paper in front of you today, we don't meet that trajectory. Just a few other things to mention. So section 2 of the paper just gives you that bit of system context and shows the challenge that each of the system partners was facing. As a system, we were around £63 million adrift of our trajectory for 2021, and that was the challenge that we were working through as a system to try and reduce. Section 3 just identifies where our financial position has changed from that November submission. Obviously, things change on a weekly, monthly basis, and there were some ups and downs, but the main thing that's changed since then was what I mentioned earlier about the change to national tariffs. Section 4 just walks through the position from 2019-20, where we're expecting to finish collectively with a surplus of £9 million across the 5 CCGs. It shows how we move from that to the planned surplus of £1 million in 2021. So whilst we had significant growth in funding, about £67 million, actually that's eaten up straight away by price increases, by activity increases. before we get to a range of cost pressures and investments. Those cost pressures and investments are listed in more detail in the appendices at the back, but includes things like the new interventional radiology unit that's in place at the Norfolk Norwich from this April. It includes things like trying to deal with the backlog in waiting times for planned care. And again, that's clearly an issue that's going to be pushed into the long grass to some extent because of the emergency response. Because of all those things, we had a significant quick efficiency challenge within our plan of about £58 million. That equates to about 3.5% of what we spend. So it's within the parameters of what we've delivered actually in recent years. Final bits of the paper, section 5 outlines some key activity growth assumptions that we played through that we discussed as a system. Section 6 talks a bit more about our efficiency and transformation program, what we used to call QUIP. And I think it's important to note that whilst our QUIP challenge was about 3.5% across the board, because a lot of our spend is now protected in areas like mental health services and community and primary care, we have to have a disproportionate amount of that savings target, that efficiency from our acute sector spend and our prescribing spend, which is why the percentages we look at there are 5% and higher. As I said before, lots of good work was happening on transformation. We've done a lot of work sharing our schemes with acute colleagues and getting them to help us in terms of working out what would really make a difference to them within the acute hospitals, what would stop activity coming through their front door and therefore help them reduce their cost base. That work was moving towards a conclusion, but obviously it had to be put on hold in particular because it was involving, probably for the first time, a lot more operational and clinical colleagues who clearly have had to be redeployed to operational response services. So a particular risk, I suppose, around transformational delivery during this period of COVID as well would be around our prescribing and continuing healthcare schemes, because the staff there within the CCG will be focused on other issues as part of the response. Final couple of comments. Section 7 looks to tell the story of how the financial plan matches the strategy, and what we'd expect to see in here over time is that our percentage growth each year in mental health, primary care and community is much higher than our percentage growth in acute sector spend. That doesn't really come across in 2021. The reason being really those two significant things I mentioned earlier about there's about £7 million spent on the interventional radiology unit at the Norfolk Norwich Hospital and £6 million set aside for dealing with backlogs. So if those things had been taken out, well, then our growth on acute spend would have been around 2.5% to 3%, so it would have been significantly less. Section 8 shows some key risks and mitigations. Clearly, all of this is impacted by COVID, as we said before. So yeah, in conclusion, it's a point in time. We'll keep this under review over the coming months. We need to still understand how the nationally calculated contract values tie in with this plan, how the changes to the commissioning of the private sector tie into it, and what it means as things stand in terms of our delivery of this, whether it helps us actually to deliver that financial trajectory we were set, or whether it poses us more challenges. Things have been evolving and emerging over the last week, so we haven't had a chance to conclude that piece of work yet. We'll also need to make sure over this period we work closely with the acute sector to understand how activity is changing, and in particular how waiting lists are growing for planned care, because when we come out of this period again, we're going to have to somehow look to address that even more significant problem as it finishes. And we will then revisit this plan later in the year. We've had a conversation with Hein about how we try to engage finance committee reps over this period to just keep some information flow and keep the plan under review. For now, though, I'm looking for approval for the plan so that we can use this as the basis for setting some interim budgets, if you like. And then, as I say, we'll bring something back for review later in the year. Let's take any questions on any of that.
Okay, thanks very much. And I think perhaps if Hein can kick off as main member with the lead for finance performance.
Thanks, Chair. So really to build on what John said, in a sort of pre-COVID-19 world, there would have been a number of salient points to discuss as a governing body, but given where we are, that would not be good use of time. It is important, though, just to re-emphasize what John mentioned, to approve a financial plan, proper governance, being able to set some interim budgets, and if only also to see how much the world has changed for the delivery of the existing practices. From my previous lay member work, I've seen the maturation of this financial plan, so there is an inherent logic to it. So in that sense, it's sound, and I would support approval of that financial plan. There are one point and one question I have, and the point I'd like to make is, as John mentioned, the significant money is going into the COVID-19 response. John has explained to me, but I'll invite him in a moment to say a bit more about what he and his team and the EM team more broadly is doing to separate as much as possible COVID-19 spend from the other spend, because I think that is important from a governance perspective. And secondly, the question I have, and I think either Melanie or John is best placed to answer it, is the mental health standard, which is pretty vital. Can you say anything about the ability to attain that, even given COVID-19, and maybe extend it also to the new standards on primary care and community? And I know they can be achieved over a longer period of time, but maybe perspective either from Melanie or John on that. But maybe I can ask John first to say a bit more about distinguishing between COVID-19 spend and the other spend. Thank you.
Yes, thank you, Han. So we've got a good process set up to capture any spend related to COVID-19. We've got a specific finance inbox which people are invited to just send things to. It can be something very vague or specific. We'll then follow up with the relevant person. I've got an associate director within the finance team that's focused on this and is linking out to other associate directors to understand the work they're involved in and how that might play through. As Heinz said, it's important that we claim everything that's due to us in terms of the real cost of COVID, whilst not overstating it. I mean, it's right and appropriate to claim the right amount. So I think there's things like the cost of staff involved in the response. We would have been paying for staff anyway, those staff anyway. I wouldn't say that that's a legitimate claim of additional cost, but there's a whole range of things that we're doing around buying extra beds in the community, for instance, to support that approach to discharging patients that we wouldn't have done if this response hadn't happened. There's lots of kit that we're buying, for instance, lots of laptops and other remote working kit that we're buying that absolutely is due to this response. So we're collecting that information. There's a template that we then have to send off to NHS England on a periodic basis for them to review at a regional level and then to support the refunding of that spend through national routes. So there's a review process there. Also, we're taking it through our exec management team on a weekly basis for two reasons, really. One, just so we've got the chance for that bit of scrutiny at exec level. Also, so that my colleagues who are heading other work streams can identify if they think anything significant is missing. I also said that I'd share that schedule on a weekly basis with Hein and Rob, as well as finance and audit chairs, just so that they've got sight of what's going through and have got the opportunity as well to question or challenge. So I'm comfortable that actually we've got a good process for collecting costs and for scrutinising and understanding them. We're also sharing across all the organisations in Norfolk and Waveney what each other is claiming for. So again, we can understand what everyone else is doing. If there's something that we've forgotten that someone else has picked up, we can make sure that we're just learning from each other. In terms of mental health investment standard, I think that's a good point, Hein. What I would say is that nationally, when they've calculated the values that we're due to pay providers, they've used the standard approach for all organisations by looking at the average spend in the first 9 months of last year, then applying an uplift. For mental health providers, there's also then a further uplift added to make sure that we do comply with the mental health investment standard. So whilst we've been having a lot of detailed conversations about a range of development areas and investments that we would look to make normally to make sure we're delivering the investment standard, clearly a lot of that's been put on hold, but we will flow the money through to the Mental Health Trust as dictated nationally to make sure that we're adhering to that.
Okay. Thank you.
Hein, do you want to come back on either of the COVID costs or the mental health?
No, that's clear. Many thanks.
Okay. Any other questions or comments for John? Yep, Mark.
Thanks, Anoop. John, just a point of information, I think, really, my ignorance, I suspect. In section 6 on page 8, left-hand side, nearly halfway down, you've got a sentence that says the areas with no QIP are either protected by investment standards or not within the CCG's discretion. Could you just expand on that a little, please?
On both areas, Mark, or the one where we don't have discretion, did you mean, sorry?
Well, both really. The
Okay.
protection by investment standards and then not within.
Certainly. So using mental health as the example, in terms of what we've referred to earlier, the way the mental health investment standard works is that every year we get an uplift in our allocation as a CCG. So this year it's 4.4% growth that we get in our funding to spend on commissioning services. What the mental health investment standard says is that we should increase our spend on mental health services by that percent plus an extra 1.7% this year. So whilst we still look for efficiency in delivery of mental health services, we still recycle that back through. So we actually spend a bigger proportion on mental health. We can't take cash out of that sector. Similarly, there's a new standard this year for community and primary care services that says we must at least increase our proportion of spend on that service in line with our percentage growth in allocation. So again, we must increase our spend in that area by at least 4.4%, which means the only areas where we have that more local discretion are acute services and GP prescribing. The comment about delegated commissioning is that our funding comes through 3 separate tranches. So the vast bulk of it is our routine commissioning funding for what's called programme services, but pretty much everything we commission from acute mental health community sector. We have a specific allocation for our running costs, which is just the staff and the governing body and elements of support services, which has come down 20% this year. And we have a third tranche of funding, which is specifically for core primary care contracts. Now legally, that's something that NHS England commissions, but through delegated arrangements, the CCG now commissions that on their behalf. As part of that, though, they say that allocation should be protected for those delegated commissioning functions. So we have to make sure we spend up to that limit on core primary care contracts. So I suppose I'm saying in terms of trying to generate money so we can then invest in other services, we have to maintain those specific pots of funding.
Okay, thanks for that. Hilary, do you want to come in?
Sorry, can you hear me? Yeah. John, earlier you mentioned that some of the changes that have happened recently have been very much accelerated by the COVID problem, so acute outpatient transformation, et cetera, I mean, some of it's just been born out of necessity, hasn't it? I suppose some of that will have very potentially positive financial implications if we can keep people working in these new ways after the COVID crisis has passed. Are you working with John Webster, or how is that being taken forward in order, I suppose, to make sure that we don't slip back maybe into old ways of doing things, and that we maintain these things that we've really been, really keen to do for quite some time?
Absolutely, Hilary. So as you say, John Webster is leading the recovery response, and my deputy Jason is linked in with John to make sure that the financial and planning aspects are front and centre of that recovery work stream. And I think there's 2 aspects really. One is the way that health services are transforming overnight with things like outpatients, but there's also something about culture of patients and public. We've talked for years, haven't we, about how do we try and stop patients inappropriately turning up to A&E? Well, A&E attendances are hard for very good and obvious reasons, but it's how can we also try and encourage people not to then go back to their previous ways maybe when we're out of the crisis. So I think there's both angles of that we need to make sure we capture. But yeah, we're very much linked into the work that John Webster's leading.
Yeah, I mean, I would just add that in that work, it's really important to work out which bits of the transformation that's happened are actually what we want to continue, because there will be other bits which we won't want to continue because they're actually not improving services, or they're actually more costly than how we did it before. So I think part of the evaluation as we go along is actually working out which bits we want to keep and what leverage we've got to make sure that they become part of business as usual going forward. But very much being minded by outcomes for patients, but also the finances as well. Does anybody else want to come in or comment on John's finance report? Yep, Arden, I see your hand shaking. Yep. We can't hear you. I think you're muted.
In terms of the prescribing savings, clearly that's a big part of the plan going forward. I presume that a lot of that is around the fantastic work that POD has already been doing, but are there initiatives to expand some of the prescribing savings across secondary care and perhaps community care as well? Is it have we got some initial plans around that?
Absolutely, Arden. So yeah, the biggest single element of that prescribing savings target is prescription ordering direct, the POD scheme that's started and been very successful in Great Yarmouth and Waveney. We've started to roll it out to West Norfolk, and it's one of the benefits of having a single CCG that we can now look to push that out across the whole patch. So that supports the prescribing dispensing of repeat prescriptions in a clinically and financially effective way. So that's had good results within Great Yarmouth and Waveney, and absolutely is a significant part of the programme going forward. There's a range of other tools and initiatives to support practices as well that are involved in the prescribing QIP schemes. And as you say, there are two aspects in terms of relating to system providers. One is around high-cost drugs, where acute providers initiate the prescriptions and then the costs get passed through to the CCG. There's some very good practice in some hospitals locally. There's some areas where the practice isn't quite so good in terms of strictly adhering to the guidelines. So there's always some opportunity there. There's always some new drugs, some new biologic drugs coming on stream that we're looking to make sure we get changes to as quickly as possible to maximise the benefit. So there's an element of that built into the programme. And also we're very aware that there's probably an untapped source of savings as well in terms of looking at that interface between secondary and primary care, things that are initiated in secondary care that might then have an impact in primary care. And it's something that Kath and the team were planning to look at, obviously, before COVID hit, but clearly that will be put on hold for now. But you're right, Arden, that's certainly an area that we're looking to explore in the future.
Okay, I think we haven't got any more requests for people to contribute. So we're being asked to approve the 2020-21 plan in its current form, mindful obviously that this is a snapshot of where we are now, and there's quite a lot of uncertainty about COVID crisis and how long that's going to take to pan out. So, can I ask you to approve the plan in its current form as requested? Yep, okay, I got lots from everybody, so we'll do that.
Thank you.
Thank you. So we're on to any other business, running about 10 minutes over, so that's not too bad. So is there any other business?
Nope, there's just the governing body meeting dates to formally approve.
Yep. So those were sent earlier, weren't they?
Yes.
Because that's part of what we're obliged to do as well, aren't we? As part of our working. So so has everybody seen those dates, including the next meeting, which is provisionally, or not provisionally, it is set for the 19th of May.
The only comment I would like to just make, you will have all seen these via email and you have got diary holds in your diaries with them. The only thing is John and I may need to change the June date, and I have just put it in the note that went round earlier. We're awaiting final guidance on the annual report submissions, which has obviously all been changed because of COVID. The indication at the moment is that we'll have to submit, I think it's the 25th of June. So I've proposed that the governing body should meet a week before our original date, which would make it, I think, the 23rd of June. We may just have to pencil that date in and just wait the final from NHS England. I don't know, John, if you have any more information on that. I haven't seen anything new.
I haven't seen anything new, but I think what was published last week seemed pretty final, I think, on that. So certainly expect 25th of June to be the date when they're expecting things to be submitted. So if we can move the governing body forward that 1 week to the 23rd, that would mean we can then take it through due process in June to have sign-off. From a committee perspective, we then look to arrange an audit committee kind of early mid-June, which would give us time to have a proper review and then have papers lined up for the governing body. So it would be more ordered actually than maybe it has been in previous years when we've had to rush to meet a deadline.
Okay, so we're being asked to approve the dates, including that bringing forward of the June meeting. Yeah. So can I ask you to provisionally approve those dates? Okay. So let's do that. Thank you. Any other business? Yeah, Mark.
Just we didn't have a chance to do it earlier on, but it seems to me we're a bit remiss if we didn't record our thanks to Melanie, Kath, and everyone at the front line who's battling with COVID-19. I thought the presentation was hugely impressive, and it's really reassuring to hear how well the system is working collaboratively. So from my perspective, best of luck for everything that lies ahead. We know things are going to get quite tricky, so best of luck with that.
Yeah, no, absolutely. And I mean, I wanted to finish on that as well, actually, but thanks for reminding me that I think we should be mindful as a governing body that quite rightly the teams are working incredibly hard, and I think we should show our appreciation to both Melanie, but also all the team that work for her within the CCG. They're actually working at weekends. You know, there isn't a they don't have weekends. Actually, it's a 7-day week operation now. So I think we should be enormously grateful for the input and efforts in it. And when I said it earlier to my staff briefing that I gave, that actually everybody is affected by coronavirus personally as well as within their working lives. Their families and friends are affected, and we should appreciate actually that people are working incredibly hard when they're also affected personally by it as well. It needs to be very much our priority in the coming weeks and months, quite likely. But it's really important that staff and you as governing body members do look after yourselves as well. So you know, the messages are out there. They apply to us as well. So do look after yourselves, including staying at home wherever possible. I won't repeat the full messages, but only go out if you need to. And one of the things that I've been saying to everybody that I see is around washing your hands. And literally, I think it is the case that washing your hands may be preventing someone from needing a ventilator in 2 weeks. So do practice what we're preaching. It's really important. Unless there's any other comments, I think this part of the meeting we should close, unless people want to make any final comments. Okay, well, look, so the next meeting is being confirmed for the 19th of May, and we'll just take a very short break for 5 minutes and then start part 2 of the meeting. Thank you.